Welcome, everybody. Welcome to those who have already signed on. We are going to give it a couple minutes to let some of our other colleagues jump on, and then we will get started. Since I was muted. Good morning, everybody. I will be brief with my introductions. I want to say thank you for everybody who was able to join us today. I will be brief because we have 4 amazing presentations that we're going to share with you today from researchers at the University of Michigan. So to start, I will say that my name is Libby Dreher-McGaughey. I'm a Director of State Relations here in Lansing, along with my colleague Sean Hammond, who is here with us today. And one of the more exciting things that Sean and I get to do in this role is make connections between the University of Michigan and the amazing work that is happening there with our legislative partners, with folks within the administration, and with the Lansing ecosystem in general. And so today's Wolverine Caucus is meant to do just that. And with October being a month focused on women's health awareness overall, we thought it was an excellent opportunity for us to have a Wolverine Caucus focused on these very important issues. So we have 4 doctors here today who are going to share their research with you. So we will start today, and I will kick it over to Dr. Peahl to kick us off. So with that, Dr. Peahl.
Thank you so much for the warm introduction and for bringing us together today. I'm Alex Peahl. I'm an OBGYN and a health services researcher here at the University of Michigan. And I am also the chair of the American College of Obstetricians and Gynecologists Redesigning Prenatal Care Initiative. It's my pleasure to talk to you today about tailored prenatal care delivery, improving pregnancy outcomes through prevention. We face a maternal health crisis in the United States. Women are more likely to die in the pregnancy episode than their mothers were. 4 in 5 adverse pregnancy outcomes are preventable, which suggests an opportunity to do better. And in obstetrics, we are lucky. We have 9 months to prevent adverse pregnancy outcomes before they happen through routine prenatal care. Evidence-based prenatal services like laboratory tests, exams, education, and support for non-medical needs can improve the health of the 100,000 women in Michigan who give birth each year. Over the last 100 years, we have seen drastic shifts in population health, innovation, and technology, with evidence-based changes in the prenatal services provided, like the addition of advanced ultrasound and genetic testing. But until new ACOG guidance this year, recommendations for prenatal care delivery remained unchanged from 1930 to 2017. That's like driving the snazzy 1930 Pontiac coupe around town today. It's just not the right tool for the job in 2025. The traditional prenatal care model is not effective for many people, particularly those who face barriers to care. In terms of access, 1/4 of patients in Michigan do not receive care in the first trimester, as is recommended. Less than half receive basic evidence-based services in a timely way, and many report a negative experience, including not feeling heard and even experiencing mistreatment. Together, these lead to missed opportunities for prevention and the persistence of adverse pregnancy outcomes that are preventable. Recognizing the need to improve prenatal care delivery, The American College of Obstetricians and Gynecologists, the leading maternity care professional organization in the United States, began collaborating with the University of Michigan to develop new prenatal care guidelines. And between 2020 and 2025, we rigorously summarized the evidence, gathered expert opinion, and engaged stakeholders to support new guidance. And here you can see the academic products of this work, many of which Dr. Moniz and Dr. Dalton also contributed to. In 2025, for the first time in a century, ACOG released new prenatal care guidelines recommending tailored prenatal care. And the state of Michigan has been an early adopter of these guidelines and is seen as a national leader in tailored prenatal care. To summarize the new guidance, prenatal care should be tailored to meet individuals' needs and their preferences. Patients should receive comprehensive screening for medical and non-medical needs early in pregnancy, and care teams should identify their preferences to inform the shared decision-making process. These factors together, needs and preferences, inform the care delivery plan in 3 areas. First, support for non-medical needs, which can include assistance or resources, and adjustment, modifications to care delivery to be more effective. For example, for a patient with transportation barriers, assistance can include ride vouchers, while adjustment can include the use of virtual care to improve accessibility. Visit frequency can be modified to be more or less intense based on the patient's comorbidities and pregnancy complications. And care modality can be adjusted, including the use of telemedicine or group prenatal care, or traditional in-person visits based on the patient's preferences. To illustrate this, I want to briefly share 2 patients' experiences. The first patient is Maya. She is a second-time mom early in her pregnancy who's worried about juggling her child in her busy work schedule along with her prenatal care. She's healthy and has no pregnancy or medical complications. And the second patient is Taylor, who's a 26-year-old first-time mom who's really nervous about her first pregnancy. She has high blood pressure and obesity, but has not yet seen a doctor for these. She just moved to Michigan and doesn't have a support network. In the traditional model, both patients would receive the schedule you see here, with 12 to 14 in-person visits, each represented by one of those yellow boxes, and the orange box representing the anatomy ultrasound. This results in overutilization of care for some, underutilization for others, and just the wrong services for many. Tailored care looks much different and is individualized to the patient's needs. Maya prefers a more flexible care schedule with targeted visits and telemedicine so she can focus on work and her family. This allows her care plan to be minimally burdensome and allows her clinic to provide additional capacity for patients with higher needs. Here you see the introduction of blue boxes to that schedule representing virtual care and 8 to 9 visits with a mix of in-person and virtual services. This is different for Taylor, who has both medical and non-medical needs. Her care plan is designed to provide increased support through more contact with her maternity care team, seen as those 12 to 14 in-person visits are yellow boxes. She also has additional wraparound services like group classes and social work support for her non-medical needs. Tailored prenatal care has been launched at the University of Michigan for about 5 years now, and we've had the fortune of seeing how high it affects patient satisfaction, with over 90% of patients saying they would recommend their care delivery. They report their visit number is just right, and that they're overall satisfied with their care. Modeling done by our industrial and operations engineering team shows that tailored models can reduce overbooked appointments by 12%, while caring for the same number of patients. We have also seen delays decrease by about 3 weeks per patient, and a decrease in patient cost of up to $800, driven largely by travel costs and lost wages. This QR code here links to a tool developed by the Center for Health Engineering and Patient Safety, which will allow Michigan clinics to plan operationally for tailored prenatal care. As part of our work with ACOG, we conducted a national listening tour to understand the barriers to implementing tailored prenatal care. We identified 4 key gaps: the need for patient partnership, for improved outpatient infrastructure, tools to address non-medical needs, and the need to measure what matters. And we have been addressing these through an MDHHS funded grant. Through this work, we have developed a Patient and Community Action Board, which is a statewide group that informs prenatal care practice and policy. For infrastructure, we conducted our Mom Map assessment, which included interviews representing over 75 prenatal clinics in Michigan. This implementation science-informed work showed key gaps in clinics' ability to implement tailored prenatal care, which will require further development of resources, training, and support. For tools to address non-medical needs, teams across Michigan recognize the importance of non-medical needs like transportation in affecting patients' ability to access and engage in care. We have developed pregnancy-specific resources and conducted pilots across the state that have improved screening and management of non-medical needs for thousands of pregnant patients. And finally, measurement. Prenatal care has historically been measured by when patients present for care and if they had a postpartum visit. This misses important opportunities to improve completion of the evidence-based services that improve outcomes. And work by our team has developed a dashboard that can identify those opportunities for improving not only the completion of evidence-based services overall, but their timeliness. Our national listening tour also identified policy priorities, including the need for continued telemedicine parity, support for non-medical needs, and coverage for self-monitoring devices. And Michigan is leading policy changes to support prenatal care through bills like HB 5167 and 68. We were so grateful to see this important set of bills that guarantee access to blood pressure monitors for birthing people with both commercial and public insurance. The new ACOG resource page will actually include this legislation as an example of best practices for other states. This is just one example of the many ways that we can partner together to improve prenatal care in Michigan. The state of Michigan can continue to lead the nation in prenatal care delivery with additional support. As one of our clinicians shared, for me, excellent care is really trying to be flexible so that people aren't falling through the cracks. As we strive to address the maternity care crisis, we need new thinking and new solutions. And tailored care that addresses patients' medical and non-medical needs is a critical step in improving outcomes for Michiganders. Thank you so much for your time and support, and I'm happy to answer any questions.
Great. Thank you so much, Dr. Peahl. I should have said at the outset that we do have the question and answer button at the bottom of your screen. Please feel free to put any questions that you have in there, and we will be sure to address them throughout the session and definitely at the end of the session. So thank you again, Dr. Peahl. We will now hand it over to Dr. Moniz. Welcome, Dr. Moniz.
Well, thank you so much, and wonderful to see everybody. All right, can you see my slides up? Okay, perfect. So good to see everybody. My name is Versha Moniz. I'm an academic generalist and associate professor. I'm also a health services researcher and an implementation scientist at the University of Michigan. And I'm speaking today with another one of my hats on, which is as the program director for the Obstetrics Initiative. And I'm very excited to tell you about that infrastructure and the ways that we use research techniques and thinking to be able to drive work in OBI, which is really focused on quality improvement. So OBI is funded by Blue Cross Blue Shield of Michigan, and my presentation today does not necessarily reflect their views. So this is our website if you want to check it out and learn a little bit more about what OBI does to transform childbirth care here in our state. You can scan that QR code and get a little more information. Our collaborative of the Obstetrics Initiative is really part of a 25-year history of statewide collaborative quality efforts in Michigan across multiple different clinical areas. So we're incredibly fortunate to have all of that institutional memory for how to do quality improvement really as a community of clinicians, patients, payers, and others that are at the table trying to do this work together. So this is our leadership structure. We're funded by Blue Cross, and we run a coordinating center out of the University of Michigan that brings together faculty, many of whom do a lot of health services research and can infuse that kind of thinking and really rigorous methods to inform the design of our work and to generate real-world evidence from the quality improvement initiatives that we're rolling out across the state. We also have some incredible staff who lead all of our outreach and engagement with our OBI hospitals. We have a data team that analyzes a whole bunch of data, which is critical for identifying performance improvement opportunities. And of course, our operations team that keeps us all running day to day. And we're very privileged to partner with the birthing hospitals in the state. They sit on our executive committee and help us make decisions about where to prioritize our focus, what initiatives to work on, what measures to track, and how to distribute incentives for doing that work. We also partner with an incredible patient community action board that Dr. Peahl runs to make sure that patients' needs, preferences, and values are at the center of what we do. And that group has decision-making power, just like our executive committee. And we have a data committee that helps us build a best-in-class clinical registry. This kind of data brings together information from the medical records of all of our participating hospitals so we can really assess performance. Some fast facts about OBI. We work with nearly all of the hospitals, with the exception of a few very tiny hospitals. We work with 68 hospitals in the state. We have over 150,000 births in our registry, so we can really understand the care that was provided during the childbirth hospitalization. And these births, even though OBI is funded by Blue Cross, our registry is all payers. It's reflecting all of the patients in our state. We have multidisciplinary champion teams at all of our hospitals. We do use pay-for-performance incentives for hospitals and value-based reimbursement incentives for physicians. All right, and I wanted to share some of the real-world results from two of our initiatives. This first one is called the Bringing Our Patients Comfort Initiative, and I am very privileged to get to work with Dr. Peahl in rolling out this work across the state. And this work was really about designing the first ever guidelines for pain management after surgery, during pregnancy, and after childbirth. So believe it or not, birth is the #1 reason for hospitalization in this country, and we did not have guidance for how to manage pain after childbirth. So these are the clinical practice guideline recommendations that Dr. Peahl led a team of national experts in generating. And you can see that one of the key areas of focus, and #2 here, is using scheduled non-opioid medications like Tylenol and Motrin as first line to control pain after childbirth. And this is just an example of what our hospitals have been able to achieve over time. So on the left-hand side, you can see vaginal births. On the right-hand side, you can see cesarean births. And the different colored lines here tell you a little something about hospital performance. So those lines in blue at the top are our hospitals that were doing well when we started this initiative. The teal and the pink lines show you sites that needed a little more support. The pink sites got some extra support from our coordinating center. And you can see that in the last couple of months of the initiative, they really start to bump up a little bit faster. And that's really useful to do this kind of analysis and for us to learn what works and what doesn't in supporting hospitals in their improvement efforts. Another key area of focus for OBI has been safely averting the primary cesarean. So first-time moms who are near their due date, trying to help prevent cesareans in that population. And we know this is an issue that is critical to patients. It really affects their birth experience. It affects clinical outcomes like risk of excess bleeding or infection. It affects expenditures. Cesareans approximately double the cost of a birth episode, which of course affects premiums, which matter to employers and all of us in the state. So we are so thrilled to be able to share that we have successfully been able to see a decrease in the cesarean rate over time. So you can see that we started with a rate of around 27.7 and went up during those pandemic years, and that number has steadily started to come down now in the last 2 years, which we're really thrilled about. And averting cesareans means fewer people having to have a surgery that maybe didn't need it. And there's one more data point we're working on adding to this slide with some analyses that are ongoing right now, and that is expenditures. So how much are we saving in healthcare costs when we're able to safely avoid a surgical birth like this? So we are thrilled to be able to share those outcomes. And I just want to thank you all for your time and attention today. And like Dr. Peahl, looking forward to hearing your questions and comments during our Q&A session. Thank you.
Great. Thank you so much, Dr. Moniz. Next, we will kick it over to Dr. Pleasant. Welcome, Dr. Pleasant.
Thank you so much. I appreciate this opportunity, Libby. I'm going to share my screen. Can everyone see my screen? Yes? Okay, I'll get started. Thank you so much for your time and attention today. My name is Versha Pleasant. I'm a clinical assistant professor and director of the Cancer Genetics and Breast Health Clinic at the University of Michigan. And the title of my study is Genetic Risk Assessment with Mobile Mammography, or GRAM. As you notice, I'm wearing pink today. We're still within the realm of Breast Cancer Awareness Month, so I had to pull out my pink blazer. But I say all that to say every month for me is Breast Cancer Awareness Month, because my clinic really focuses on exclusive care for people at high risk for breast cancer and breast cancer survivors. My only disclosure is that I'm the owner and consultant for Pleasant Consulting LLC. I give lectures on cancer genetics. Let's first take a step back and talk about breast cancer in the United States. There's a 13% prevalence, so it is the most commonly diagnosed cancer among women in the United States and the second leading cause of cancer death after lung cancer. 1 in 8 women will be impacted. So think about 8 women that you know in your life. Often when I give this talk, people have either been personally affected by breast cancer or they know someone who has been. And every 2 minutes, there's a new breast cancer diagnosis. So think about, by the time I'm done this presentation, how many new diagnoses there will be in this country. Again, this is just American Cancer Society showing you where breast cancer falls. Most commonly diagnosed, second leading cause of cancer death. So I like to think of creative ways to address the burden of cancer, breast cancer in this country. And one of the ways in which we can do that is using precision medicine. And specifically, genetic counseling and testing is the cornerstone of precision medicine. And it can help us to identify people who may be at elevated risk for breast cancer and other cancers. It helps them to helps us to identify them early and offer earlier screening, sometimes more intensive screening, and risk reducing options, which could decrease the risk of someone dying from a cancer and improve their outcomes, and definitely improve the quality of one's life. I can't give a presentation about genetic testing without mentioning Angelina Jolie, right? She is the face of BRCA and genetic counseling and testing. Her mother had breast and ovarian cancer and unfortunately passed away. Angelina Jolie got genetic testing, found out she had the BRCA gene mutation, and went through with the necessary medical options, surgeries, and interventions to decrease her risk of getting those cancers. And I tell people, yes, Angelina Jolie is rich and famous, but all of us have access to the same services and options that she had. And my goal is to help people to leverage that and take advantage of that. So how do we determine if someone meets criteria for genetic testing? Who should get genetic testing? And the assessment always starts first with gathering a family cancer history. That is one of the most important windows into a person's personal risk. So in order to start the breast cancer risk assessment, they have to sit down with a healthcare provider, talk through their family cancer history, and see if they meet criteria for genetic counseling and testing. But unfortunately, this is not something that is routinely done in the United States. Amidst all of the other competing priorities, healthcare priorities in the United States, this is something that tends to get pushed to the back burner until it suddenly becomes urgent and someone unfortunately may be diagnosed with a cancer. But I want to bring to our attention the American College of Radiology guidelines that said that all women should have a breast cancer risk assessment by age 25. We have the National Comprehensive Cancer Network, another medical society in the United States that, again, reiterates that individuals should undergo breast cancer risk assessment by age 25. And again, this is not something that's routinely being done in healthcare today. So one of my questions was, what if referral was not a barrier. Oftentimes, we find that the people that get referrals to genetic counseling and testing are either really super motivated healthcare providers or self-selecting patients that come to their healthcare provider and say, gosh, I have a really strong family history of cancer. I'm worried. Can you refer me? And my other question was, what if we coupled genetics with breast cancer screening, right? People are already coming to get a screening mammogram. They're already thinking about breast cancer. What a better time to then discuss their potentially elevated risk of cancer and refer them to genetics as indicated. And that's where we got this project idea from. Genetic risk assessment with mobile mammography. It's kind of a play off of mammogram. And University of Michigan has a mobile mammography unit that has seen thousands of patients at this point. And what we decided to do as a component of this study is that we had our study recruiter previously sitting in a tent, but in colder weather would actually be sitting in the mobile unit. And she would approach every patient coming to get a screening mammogram and say, hey, are you interested in having a risk assessment today? And she would sit down with the patient and go through our software tool and enter their family cancer history, which would automatically flag and let us know if they should see a genetic counselor based on their family and personal history. And if they met criteria, then we would provide them directly with a referral to see a genetic counselor. There was no need to go through their primary care doctors. So the aims of the study was to evaluate the feasibility of offering genetic counseling referrals outside of the primary care setting, to determine patient acceptability of the risk assessment at the time of screening mammography, and to evaluate the effectiveness on the access to and uptake of genetic counseling and testing. These are the most recent NCCN genetic testing guidelines. And if you look at them hard enough, they might make your eyes cross. It's very text heavy. It can be very confusing for providers. So what our software tool does is you enter family health information, it links to the NCCN criteria, and it'll tell us immediately, meets guidelines or does not meet guidelines. So here are some basic demographics of the patients that enrolled in our study, with most of them being in the 41 to 60-year-old range, many of them being white and many of them having private insurance. We screened and recruited over 106 exactly patients, and 54 of them screened positive. 54. So that is half of our study cohort screened positive, meaning that they met criteria to see a genetic counselor, which is really astounding. All but one was referred to the genetic counselors. One patient requesting not to be referred, and she needed some time to process things. 33 of them made appointments. 18 of the 54 completed genetic testing, and 11 patients were recommended to have another family member undergo genetic testing as opposed to them. And the results show that 13 of the 18 had negative results. One person had a positive result in a pathogenic or germline variant, meaning a gene that's passed down from generation to generation, such as BRCA. 4 people had equivocal results, and 3 of those 18 actually, even though they had negative genetic testing results based on family history alone, they met criteria for more intensive breast surveillance with breast MRI, which is known to detect breast cancers at earlier stages. We're really, really excited about these results. And in addition to that, we also conducted a survey after the risk assessment. We did a convenience sample. 79 people completed the survey, and 78 out of 79 said that they were satisfied with this breast cancer risk assessment. 94% said that they were actually never offered genetic testing or a breast cancer risk assessment by a healthcare provider. Some of the qualitative feedback that we got, people said, I'm grateful for the opportunity to take part in this important research. This was wonderful and very informative. This was a very friendly and calm way to learn about genetic testing. The comfortable location and warm, positive interactions with the study recruiter made the assessment. Very pleasant approach, non-threatening, comfortable, and safe, both with the screener and the location. I found the mobile services for screening convenient and didn't mind the additional assessment. Well done. Always happy to support research on women's health. Thank you. We also coupled this intervention with education because we firmly believe that you can't just offer a service to patients and expect uptake without also coupling it with information as to why that service is critical to their health. And these are just some of the locations for which we performed events over the past year. We actually did many more than that. And we would go out, hand out flyers, talk to people about their family cancer history. We had a breast model. We would teach people to do self-breast checks. These were really important moments to engage the community and teach people about the importance of breast cancer awareness. where are we moving in the future with this project? So right now we're in a second phase of this project where we're exploring patient barriers to genetic counseling and testing. If you notice, there was quite a bit of drop off for people that screened positive and people that actually completed their appointments. So we want to explore why that is, because we want to help make this process as streamlined as possible for patients. We also want to try to scale up the Graham study and figure out how we can make this screening available to all women across the entire country. This is something that should be routinely being done, and the time of mammogram is the perfect opportunity to do that. But in addition, though, if we go back to those national guidelines that stated that people should have risk assessment by 25, well, if we recall, the general guidelines for breast cancer screening start at age 40. So if we're supposed to be screening people by age 25, we may be missing the mark if we only do this at the time of mammogram. So I'm launching another study called Genetic Risk Assessment with Screening, PAP or GRASP, because generally cervical cancer screening in this country begins at age 21. And so why not also couple a cancer screening with another cancer risk assessment? And so we're going to launch this project to explore how we can pair the breast cancer risk assessment with a screening that is routinely and universally done, which is screening for cervical cancer. In conclusion, early detection can really save lives from breast cancer, right? We're not just talking about knowing information for knowing information, right? Early detection, identifying people at high risk, this can actually save their life from cancer. And breast cancer risk assessment is the first step in identifying that risk. And in order to really hone in on the most effective entry point and delivery model for the risk assessment, we need to continue to do this research. It is really critical to our work, and it's critical to improve people's lives. I want to thank you so much for your time and attention, and happy to take questions later.
Thank you so much, Dr. Pleasant. I will do one more plug for folks to put questions that they've developed so far, and while Dr. Dalton is speaking, into the Q&A, so we can address them at the end. And with that, we will tee up Dr. Vanessa Dalton.
Okay, I want to confirm that you can see my slides. Okay, great. Well, good morning, everybody. And I am really grateful to have the opportunity to speak to everybody today. I'm a health services researcher and a professor in the OBGYN department, as well as a practicing gynecologist. I direct a health services research program that we affectionately refer to as POWER. And I think before I make any more comments today about any the specific work I'm going to talk to you about, I just want to say that I'm representing a really large group of people. And out of consideration for everybody's time, I'm not going to necessarily go into introductions for all the people that do work on this, but I am happy to make introductions if people want to email me about anything specific. Anything specific I talk about today. So POWER has a mission to really focus on improving health through research on health services and health policy. We have a pretty large body of research, but the three that I would say are sort of the major focus for us right now is looking at the impact of state health policy on mental health, suicidality, and intimate partner violence. We also have a series of projects looking at the impact of Title X, as well as other safety net services on community health and reproductive health outcomes. And then this last bullet point is on some work looking at the variation in fibroid care pathways, which I'll talk about more specifically today. But I'll begin with talking about it. Let me see if I can do this right. There we go. Talking about our work on, now you guys are not moving forward, I see.
It did move forward.
Oh, it did. Okay. I'm going to talk a little bit about our work on perinatal mental health. As many of you here know, and both Alex and Michelle had commented on this, there's been a considerable amount of work in the last couple of decades around mental health around the time of pregnancy. And mental health related conditions, again, many of this group will know, are major contributors to maternal mortality and morbidity in the United States. And so with that in mind, identification and treatment of mental health conditions around the time of pregnancy is a key objective, so that early intervention can occur. There's a variety of policies that have been studied around the country, including things like safety bundles and policies around reimbursement for screening, as well as expanded coverage of mental health services. And much of our work has focused on that, but I thought what I would share today is very specific to Michigan. What I'm showing on this slide is is data from a very unique data source, which is Michigan Medicaid linked to Michigan PRAMS data. Michigan PRAMS data collects information on symptoms, and self-reported symptoms in Michigan are quite high amongst people for anxiety and depression amongst people who just recently had a baby. And what this slide shows you is among people who report having symptoms or screen positive for depression, what proportion of those patients end up having documentation in their Medicaid claims of a diagnosis. And what you can basically see is there's a considerable amount, there's this big gap, meaning that only 50% of pregnant women with symptoms that are consistent with depression actually have a diagnosis in their medical records, meaning we have a real missed opportunity to identify folks and intervene during pregnancy. The other thing I want to point out about this is that we are using PRAMS data, which is one of the only sources to get self-reported symptoms during pregnancy that can generate population-based estimates. We are very fortunate in Michigan to still have a PRAMS program that is working with us. But this is not true across the country, where a lot of states have really rolled back or restricted their activities and collecting information amongst pregnant people through PRAMS. The other piece that I wanted to touch on is while there's been a lot of information generated in recent years around mental health during pregnancy, we really lack information about mental health in women in the lifespan. And there's a lot more interest in this topic, I'd say, in the last couple of years. And this is just to make the point that mental health continues to be a very common condition that folks struggle with throughout the lifespan. And just this is data from national Medicaid data showing that 1 in 4 mid-age women, which by that I mean 45 to 64-year-old women enrolled in Medicaid, also have a mental health diagnosis. And it does seem to be peaking around the years of menopause. So menopause and mental health is not very well understood. We do know that about 70% of women report psychological symptoms around menopause, including symptoms consistent with depression and anxiety. But it's not clear. We don't totally understand the relationship between mental health conditions and perimenopausal changes. We also, for example, it's unclear whether the role of hormone changes during the menopausal transition can contribute to exacerbation of underlying mental health conditions. But there is some early data to suggest that there's probably an association there. And there's the other consideration is during that period of our lives, there are a lot of other risk factors that may be more common than in younger years, including social stresses, financial stresses, and stressful life changes. Our group is moving into studying this more specifically, and I wished I was going to be ready to present the data for you today, but we had the opportunity to add some questions in the Michigan poll on healthy aging around menopausal symptoms, and they already collect information about mental health symptoms. And so we'll have a better idea of how these two conditions or these two situations overlap. And I'd be happy when we have that ready to share that with the group. The last project I'm going to talk about is a little bit of a shift, although we will be looking at mental health amongst this in this project as well. This project is intends to look at fibroids as fibroids are small, usually benign tumors of muscle that grow in the uterus. They're incredibly common. So by the age of 50 or so, about 70% of women have fibroids, and it is disproportionately more common amongst Black women. And as part of a program called Peace that's run by Erica Marsh, I'm going to contribute some a project that will examine the pathway by which people go through fibroid care to determine whether or not that contributes to the variation in outcomes. So what we do know is that people's experience with fibroids varies considerably in terms of what age they get fibroids, what kind of treatment they have, and what kind of outcomes they experience. Fibroids can cause things like heavy bleeding, it can cause infertility. And so understanding, for example, at what point people have hysterectomy, which removes your fertility, is really important. What we also know is that variation is not completely explained by clinical factors. So individual preferences for treatment, the age of onset, these things don't totally explain the differences that we see. So one of the first steps that we did was to look at just identification of fibroids amongst women enrolled in Medicaid in Michigan and how that, whether or not there's variation across the state. In other words, is your likelihood of getting a fibroid diagnosis different if you live in one part of the state versus another? And what I'm showing you here is the answer to that question appears to be yes. This is showing the rate of getting a fibroid diagnosis, which I just want to point out doesn't mean that's not the same as actually having fibroids. That means you went to the doctor identified your symptoms as possibly caused by fibroids, and then you got the diagnosis. And what you can basically see here is that if you live in the eastern part of the state, you are much more likely to have a fibroid diagnosis by the age of 55 than if you live in the west part of the state. And so the next step with this work will be to determine more granular information about what happens when people go to the doctor with symptoms that could be consistent with fibroids. And don't have that information for you now, but that is the direction that we're taking now. And with that, I will turn it back over to Libby, and here's my email. And if anybody has any questions, I'm happy to address them.
Great. Thank you so much, Dr. Dalton. All right, well, that concludes the sharing portion of just some of the amazing research that's happening around women's health issues at the University of Michigan. We did have one question to ask, and I think it can go to all of you. It's a fairly broad question, but given the information that you shared today, what could the state of Michigan do to prioritize support for the research that you're doing from the state level? I don't know who would like to go first.
I can jump in, Libby. I think, we often think about healthcare quality improvement as something that just gets baked into operations. And I think, there's a lot of people doing this work on nights and weekends outside of their full-time job. And I think we've done a lot in the state to invest in quality improvement work over the last few years. And that is a critically important step and commitment that we've made, that not only do we deliver care in the state, but we are learning constantly how to do that better. And I think one area we haven't fully resourced yet is evaluation. So it's one thing to deliver quality improvement and to try to be doing that improvement work, but we really often are operating without an evidence base within quality improvement. So we need, just like we need clinical trials research to help us know what care to give an individual patient, we need research on quality improvement to know what support do we need to give each hospital, each clinic, each provider at moments in time to best drive improvements in care delivery. So kind of thinking about precision medicine, where we learn things about an individual patient and tailor their treatment plan, we could apply that kind of thinking to quality improvement. And I think that could really help us become better and drive towards better health outcomes more rapidly. But that requires investment in that evaluation piece.
Great, thank you. Does anyone else have anything to add? Dr. Peahl?
Sure. I'd love to just build on what Dr. Moniz is sharing. Not only is this work often done on nights and weekends, but it requires additional dollars from external sources to get to the data that we need in order to make decisions. And even when we're bringing in that additional information, it's often incomplete. So for example, one of the main tools in our health services researchers toolkit is claims data, looking at insurance claims from both publicly and commercially insured patients. But there are huge gaps in that data. Like, we cannot know how far along in pregnancy someone is from a claim, which makes it really hard to understand, did they receive services in the right time frame or the right care for their place in pregnancy? We are on the threshold of having some really exciting new data sources available to us. Specifically with new health information technology infrastructure, we are starting to build the scaffolding to take information directly from the EHR and use that for our traditional reporting for quality through programs like HEDIS and CQA and CMS. But that creates a new pool of data for us to do this amazing work, and that doesn't require outside information, doesn't require another structure. It will be right there for us. These transitions are huge. They're hard to wrap our heads around. They're out in the cloud and pulling data from sources in ways that we aren't used to. But I think partnership from the state in thinking about how do we treat that as a statewide commodity and a statewide imperative is really a promising avenue for us to explore together. I also just want to echo the need for infrastructure support. We talked to 75 clinics across Michigan, and when we said, hey, how are you managing prenatal care quality? They said, oh, I guess I'm the clinic leader, that's my job. But we didn't have the same quality infrastructure that we see in our inpatient settings. Investment in that outpatient space is really critical to shift some of our skills and our ability to prevent rather than just secondarily manage. We have to get care right in the inpatient setting, and we have to help our inpatient colleagues to have patients optimized as much as possible for their birth hospitalizations.
Great, thank you. Dr. Dalton?
Yeah, I mean, I think that we have been very fortunate in having partnerships over the years with the state and getting data access. So even beyond claims data, but for example, the PRAMS program being a great partner. We've worked closely with other. I'm not sure what units they fall in, but other units that have collected data and provided it to us in granularity that was different than what would have been publicly available. And I think that's really important. And I have no idea if this is true or not, but I have heard some concerns that perhaps we won't be collecting public health data in the same way moving forward than we have in the past. And I think that is very concerning.
I would love to advocate for any support of cancer prevention initiatives. Cancer is a very, very expensive endeavor. It's expensive emotionally, it's expensive physically for the patient, and financially, and it has ripple effects to not just the patient, but everyone surrounding them, loved ones and family members. And so I wake up every single day because I hate cancer and I love finding creative ways to prevent it. And for people at high risk, I love bringing them in and making a plan for their lives so that we could either reduce their risk of getting it in the first place, or we can detect it early so that it's treatable and that it's still within a reasonable stage. So, anything that is related to cancer prevention, particularly breast cancer, because as we mentioned, is the most commonly diagnosed cancer among women in the United States. Women need more access to mammogram services. And one of the really exciting things about the project that we did with the Graham study, it was at a mobile mammography unit. And we had a really, really high reception and uptake of this service, right? And so we're reaching communities that may not necessarily have had access to a brick and mortar radiology unit, which is the case in many places in the United States. So instead of saying, gosh, this is an impossible endeavor to make mammography available to all women, we can take mobile units out to people if there's no unit, right? And we can reach underserved communities that way. There's a lot of attention right now on breast density. And if any of you want to talk about that offline, I'm very happy to talk about it. But another thing that's coming up in primary care is that patients who may not necessarily have a family history or a gene mutation, they may be at elevated risk for breast cancer simply due to having dense breast tissue. And we have a law in place now that requires us to tell patients that they have dense breast tissue, but we have nothing to offer them after frightening them and telling them that they're at increased risk for cancer. And so here's a great opportunity for legislators to really think about what can we offer to patients, right? We know that breast MRIs are really sensitive studies. We know that they can detect breast cancer early, but there's no sort of unanimous and universal way in which we talk to patients and counsel them about this and offer them these services. These are things that really must be covered by health insurance companies, and again, can downstream really cut not only costs, healthcare costs, but also save lives from cancer. So I would really encourage all of us to think about that moving forward.
Great, thank you all. I haven't seen any other questions come in from the group. So I will just open it up if there are any final thoughts that any of you would like to share before we bid everyone adieu. Great. Well, you all, thank you so much for sharing just a little bit of the research that you are doing it's having an incredible impact on the state of Michigan. Thank you to all of our participants today, legislators and staff. We definitely appreciate you taking the time to join us. We will continue to be having Wolverine Caucus meetings like this moving forward. If you have an idea of something you think would be interesting for us to gather folks from the university on, I can tell you that we have experts in just about every corner of everything that you could possibly come up with. So again, this being the tail end of Women's Health Awareness Month, we are so grateful for Dr. Dalton, Dr. Pleasant, Dr. Peahl, and Dr. Moniz for joining us today. And we will be in touch soon about the next opportunity to join us to learn more. Thank you so much.
Thank you, everybody.
Thank you.
Thanks so much.
Thank you.